Welcome, everybody. We will be starting in 2 minutes. Thank you for joining us today. For anybody who has just joined us, welcome very much, and we'll be starting in about 1 minute. Great. In the interest of time, we will start the presentation. Hi, everybody, and welcome to the Leukemia and Lymphoma Society of Canada's National Leukemia Conference. So we have hosted this conference for 3 years now. This year is definitely the first of its kind as we come together virtually. Thank you for adapting with us. Throughout the week, we will share educational tools on leukemia as well as stories of hope. This week, you can expect 4 more webcasts on ALL, AML, CLL, and CML. In today's presentation, we will learn more on leukemia research advances, stem cell transplants for blood cancers, and the complications that can arise in leukemia and stem cell transplants. My name is Netta Pajuman, and I'm the Regional Director for the Ontario region at the LLSC, and I will be your moderator today. The presentation will last approximately 90 minutes, which includes a question and answer period. Please feel free to get up, stand, and stretch. Your cameras are off, and it won't be a distraction to our speaker. We invite you to type your questions and comments in the question box of your GoToWebinar panel throughout the presentation. An LLSC staff member will be monitoring and can answer any technical or program-related questions. I will ask some of your questions to Dr. Munshi at the end of the presentation during the question and answer period. Due to the number of questions, we may not be able to get to answer all the questions posted, but we'll make sure to reply to you outside of this session. The conference is being recorded, and therefore you can listen to it again on our website or share with your family. We will email the link to you after this event. As we prepare to begin our main presentation, I want to take a few minutes to share our mission here at the LLSC and to highlight some resources that might be very helpful to you or someone you know. I like to think of LLSC's mission as twofold. We look to the future of care through research, where we aim to find a cure for blood cancers, meanwhile addressing the challenges today by offering services to improve the quality of life of those affected by blood cancer and their families. Ultimately, we are here to serve you. We offer support and guidance to people affected by blood cancers along the way. It's important to us to remind you that you're not alone. Please don't hesitate to contact your local community service manager to learn more. We offer a variety of educational resources and support services to help those affected by a blood cancer. On our website, you can access informational booklets and fact sheets about blood cancers, treatments, and psychosocial aspects of your journey. You can access our resources in a variety of languages, eliminating any barriers related to access. We also have various educational videos to fully understand blood cancers and treatment management. Our website, on our website, you will also find the recordings of all of our past webcasts and of course announcements on upcoming LLSC webcasts. We encourage you to subscribe and listen to our podcast series, The Blood Cancer Experience, to learn more about treatment and research from experts and to hear stories directly from people affected by blood cancer. Our podcasts are available on Spotify, Apple Podcasts, and anywhere you enjoy listening to your podcast. Sometimes it really is best to hear from someone who has shared experiences to what you're going through. Our peer-to-peer support program is a support service that matches people affected by blood cancers, caregivers, and their families with trained volunteers who have been touched firsthand by blood cancer and have shared and similar experiences to yours. It is a supportive program which is especially relevant today during COVID, where we hope it counters the effects of isolation. So while 2020 is not a year filled with many highlights or things to celebrate, we are proud to share that in June of 2020, we launched a new program called Your Life After Cancer. For the majority of people, the transition between being a patient to being a survivor is not so seamless and straightforward. We know that every cancer experience is unique and that every step has a deeply personal impact and meaning. This program offers tools and resources you may need to help you move forward after your blood cancer experience. You can visit yourlifeaftercancer.ca to view our new fact sheets on important topics such as fatigue, cognitive issues, and how to support loved ones in their transition. You will also find webcast and podcast recordings along with inspiring stories from survivors. Okay, now what do you say we move on to our main topic of the day, critical illness? It's my pleasure to introduce our speaker, Dr. Laveena Munshi. Dr. Munshi is an assistant professor and critical care physician at Sinai Health System within the Interdepartmental Division of Critical Care Medicine at the University of Toronto. She has research interests in critical care of the immunocompromised and oncologic patient populations with an early focus on hematologic malignancies and acute respiratory failure. She has completed her master's in clinical epidemiology at the University of Toronto. She was supported by a Canadian Institute for Health Research Fellowship Award during her graduate work, as well as the Elliott Phillipson Clinician Scientist Training Program. Her research, which was funded by LLSC in 2017, is a multi-center national study evaluating short and long-term outcomes of critically ill patients with hematologic malignancies. She is the co-founder of the Critical Care Oncologic Investigative Network, a local initiative established to improve quality of care and communication between oncology and critical care. Please join me in welcoming Dr. Munshi.
Thank you for that introduction, and thank you to the Leukemia and Lymphoma Society of Canada for giving me the opportunity to present today on adult critical illness, what we do as critical care physicians, and specifically on this topic of critical illness across patients with leukemia and stem cell transplant. And I'm particularly excited to present at this conference because this is really the way of the future in terms of informing what we do as physicians. So following the presentation, there'll be a Q&A, but I also have my email address, and I absolutely would love to hear your insights, your thoughts, your reflections, and any advice that you may have for us moving forward in terms of our approach to thinking through research for the leukemia and stem cell transplant population with the lens of critical illness. So as you heard, I'm an assistant professor and I'm an adult critical care physician at Mount Sinai Hospital at the University of Toronto here in Toronto. I have no relevant financial disclosures for this presentation, but I'm very fortunate that our research is supported by the Leukemia and Lymphoma Society of Canada grant, as well as an innovation grant that we've received from the University of Toronto. So this is a picture of Mount Sinai Hospital, and we currently work on the 18th floor, which is where the critical care unit is. About 50% of the adult patients that we manage in our critical care unit have an underlying diagnosis of cancer, and a large cohort of those patients have an underlying hematologic malignancy. So of the patients that we manage, we have a lot of expertise in the care of patients with leukemia and stem cell transplant who develop critical illness during their treatment. We're geographically situated right next to Princess Margaret Cancer Center, and therefore we're the critical care unit that responds to any emergencies that arise at Princess Margaret in patients undergoing treatment. So over the next 40 to 45 minutes, what I thought I would do is start with a brief overview of adult critical care medicine and what it is that we do in our intensive care unit. And I thought that would be important for us to then establish a platform for me to talk about what's unique about critical illness across patients with leukemia and stem cell transplant, because there are some very unique causes of critical illness and ways that we think we should be managing critical illness. I'll briefly talk about the frequency of critical illness across this cohort of individuals, and then present a little bit more data around critical care outcomes of patients with leukemia and stem cell transplant, and elaborate a little bit on some of the preliminary results of our COHO study. And I'll spend the last little bit talking very briefly about some of the new therapeutics in cancer care, particularly for leukemia, and the implications that they have for us as a critical care community. So many of you may be familiar with intensive care medicine and critical care medicine, and certainly we've been in the news a lot most recently with the COVID-19 pandemic. But for those of you that may not be familiar with critical care, we're a subspecialty in the hospital, and we basically oversee care that is administered in the intensive care unit of a hospital. And what an intensive care unit can do is provide advanced monitoring for a particular patient. So we can watch much more closely the state of the heart or the state of the breathing or level of consciousness. We can also institute specific therapies or institute treatment using machines for organ support, such as artificial respirators or what we call mechanical ventilation when people have breathing failure, or what I'll refer to as acute respiratory failure. Key medications for cardiac support when either the heart is failing or if the blood pressure is critically low, which can sometimes happen in the setting of severe infections. And that's important because then blood flow to the organs becomes reduced, and that can cause organ failure. And there's a certain type of slower and more gentler dialysis that we can run in the ICU that we can administer for people who have kidney failure. And in the ICU setting, in addition to the advanced monitoring and the different therapies that we can run, the ratio of nursing to patients is 1-to-1 or 2 patients to 1 nurse. So it's a much more intensive location for care to be administered. And across our group of 6 ICU physicians that run our intensive care unit, which has anywhere from 18 to 21 beds, we have 1 to 2 ICU doctors that are taking care of our ICU patients for a week, On a weekly basis, we meet and we discuss all of the patients in depth with all of our ICU group to get everyone's insight on the care. And then we change on a week-to-week basis, which we think is important because every week there's a new set of eyes and fresh ideas that are added to the care of the patient. This is just an idea of what an ICU room may look like. As you can see here, it's blacked out by partially by the circle, but what normally happens in the mouth is you may see an endotracheal tube, which is the tube that's inserted for the delivery of artificial ventilation. This is our mechanical ventilator that we use when people have acute respiratory failure or breathing failure to help support the lungs through that critical illness. You may see a lot of IV poles, and this is where our cardiac support medications, such as things called vasopressors or inotropes, are administered, and they get administered either through a peripheral intravenous line or a central line. And oftentimes, because many of our patients are asleep or in a medically induced coma, we still need to administer nutrition. And sometimes we administer nutrition through a nasogastric tube. So it's a small tube that goes into the nose or mouth and into the stomach to enhance nutrition, or through an intravenous line. When we think about the general population, the two most common reasons for people to develop critical illness are either due to sepsis or respiratory failure. Now, sepsis, as many of you may be very familiar with, is basically a very severe infection that develops in the body. And as you can imagine, your body tries to clear that infection. But in doing so, in the immune response that your body creates to try to eradicate the infection, sepsis occurs when you have a dysregulated immune response, so almost an overactive immune system. And while it's successful in trying to eradicate the organism that caused someone to be sick in the first place, the overaggressive or dysregulated immune response that develops can cause the blood pressure to go critically low, or it can cause inflammation to other organs, such as the lungs or the kidneys. The second most common cause of critical illness that we see in the general population is acute respiratory failure or breathing failure, or some more severe form is called acute respiratory distress syndrome. And once again, there's been a lot more press on respiratory failure given the COVID-19 pandemic. And people can develop respiratory failure through any sort of organisms or bacteria, fungal infections, or viruses in the community. And sometimes it could be so severe that the lungs are not able to operate on their own, and we need to escalate to invasive mechanical ventilation. In terms of survival rates across the general population, the majority of people that we're bringing to the ICU who develop sepsis or acute respiratory distress syndrome survive the ICU and are able to leave the hospital. So what is unique about critical illness across patients with leukemia and stem cell transplant? So there are some very, very important differences that are necessary for ICU doctors to be aware of when we're managing these patients. So oftentimes in the general population, people may acquire an infection from the community, pneumonia, for example. However, in the setting of hematologic malignancies, particularly leukemias, and in particular patients that are undergoing stem cell transplant, it's not uncommon that the critical illness develops as a consequence of the treatment that that individual is receiving for the underlying disease, which is being given with curative intent. And when critical illness may develop, it's our job as ICU doctors to try to support that individual through the critical state, so we can buy time to ensure or see if that definitive treatment has actually taken effect. The second thing that's very unique is the average age of adult patients who develop critical illness and come to the ICU is in the 60 to 70-year-old range. However, there's a larger portion of patients who have underlying blood cancers or hematologic malignancies that tend to be young presenting to our ICU, and they have few other medical conditions. As you may hear in the news, many people with COVID-19 that are being admitted to an ICU may have other medical conditions such as high blood pressure or diabetes, but a larger proportion of our hematologic malignancy patients have no other conditions other than their new blood cancer that they might have developed. The third thing that's very unique about this population is oftentimes there are unusual disease processes that can complicate treatment. So unique drug-associated toxicities that may cause inflammation associated with the lungs that may lead to the development of critical illness necessitating admission to an intensive care unit. On top of that, sometimes we have a combination of infectious and non-infectious causes of critical illness that warrant ICU admission. And so we as critical care doctors need to be aware of the spectrum of things that can cause breathing failure or sepsis or syndromes that look like sepsis that lead to an intensive care unit admission. And finally, which is probably one of the most challenging things that we as ICU doctors face, is that if an individual has what looks like sepsis, so severe infection, or if they develop respiratory failure, the underlying cause of it is not always easily identified. And the reason why that's important is because we're trying to identify what is the precipitant of critical illness so we can actually target treating that while trying to bridge an individual and their organ failure through the state of critical illness. When we reflect upon what the purpose of intensive care medicine is, some people say, well, it's very obviously the purpose is to bridge individuals to survival, and we're in complete agreement with that. However, more and more as we spend time in the practice in the domain of critical care, what's also very important is to ensure is that we're not just bridging individuals to survival, we're trying to bridge them to a state where they have, at the end of it all, a meaningful quality of life. And that's for the general ICU population. In the setting of cancer and in the setting of blood cancers, we have a few other additional goals. So in addition to survival, and in addition to bridging someone through their treatment toxicity to a meaningful quality of life, we're also trying to ensure that the quality of life that that individual has at the end of their critical illness is still a quality of life and a level of function that still makes them a candidate for ongoing treatment. So there's additional objectives that we need to be thinking about when we bring patients with cancer to an ICU. Now, there are many time points at which an individual with cancer, and in particular blood cancers, from the moment of their diagnosis to their outcome, could develop critical illness. And it could be at the new presentation of the disease when it's being diagnosed. It could be during induction when they get the first round of chemotherapy. It could be the peak of their treatment toxicity, so maybe 10 to 14 days after chemotherapy is administered and the neutrophil counts are very low. That's when we really tend to see the greatest susceptibility to sepsis and breathing failure, or it could also be during remission. And when I do teaching for the residents and fellows, I often show them this slide, and obviously I'm not going to go through this in detail, but this gives you a snapshot of the different time points and the different conditions that can occur. So it's important for us as critical care physicians to be very familiar with the underlying blood cancer, the treatment that we're receiving, and the types of complications that could arise. Furthermore, at the end of this presentation, and likely something you'll hear a lot more about over the next couple of days, there's been this revolution in cancer care, and a lot more new therapies are coming about using the approach of precision medicine. And these are very exciting therapies. But it becomes very important for us as critical care to be familiar with these therapies because they're also associated with novel treatment-associated toxicities that may require critical care support to bridge people through the inflammatory states that may develop as a consequence. So given the multiple time points at which an individual with blood cancer, leukemia, stem cell transplant may develop critical illness, it's absolutely essential that we have great communication and collaboration between our ICU teams and our oncology specialists, which we've definitely established between Mount Sinai and Princess Margaret Cancer Center. So when we think about the frequency of critical illness across patients with hematologic malignancies, as you probably know, only represents about 10% of all cancers. However, if you look at every individual cancer, hematologic malignancies are at the highest risk of developing critical illness across all of the different subtypes. And the reason why that is, as you're probably very aware, is that the treatment necessary for these blood cancers can really suppress the immune system, which then predisposes individuals to developing severe infections and respiratory failure. Now, the data that I've shown here in this graph is the likelihood of developing critical illness during treatment. And as you can see, it's higher for hematologic malignancies and even higher for acute myeloid leukemia. And across some reports in the US and Europe, even higher for certain patients with stem cell transplant. Now, the incidence of ICU admission is very variable across different reports and across the world because different ICUs have different thresholds for admitting patients and different severity of illnesses across which they may admit patients. But one of our PhD students is actually looking at this data specifically for Ontario. And what he's found so far in his preliminary evaluation across the past 10 years is about 13% of patients with hematologic malignancies are admitted to an ICU within 1 year since their diagnosis. And about 22% of patients with acute leukemia are admitted to an ICU within 1 year. So those numbers seem to be consistent with what we're seeing reported internationally. Now, what are the outcomes of patients that actually develop critical illness? But maybe to take it a step back, let's reflect again on the goals of an ICU admission. So once again, the ultimate goal is survival. But as everyone here is very well aware, life is much more than just survival. And so in order for us to make an informed decision and provide sufficient information about what we can and cannot do in the ICU with all of the technology and medications that we have, we as ICU doctors really need to understand what individual patient preferences are. What is a meaningful quality of life? Oftentimes, when a patient gets admitted to the ICU, I don't have an opportunity to actually talk with that individual patient because of the critical illness, causing them maybe to be obtunded or in a coma. And oftentimes, I have to learn about that individual through the family. And in some cases, a family may tell me that Bobby's hobbies included gardening and traveling and biking. And when I ask them about, well, what would be a meaningful quality of life for Bobby, they may say a quality of life just where he has the ability to bike and travel and garden. On the flip side, some families may say that their loved ones' hobbies were also gardening, traveling, and biking, but they would be okay, they think, with a quality of life where they may not be interactive and they may not be as active, but as long as they can interact with their loved ones, that may be an acceptable quality of life. So that's important for us to understand as we take care of patients in the ICU. Because we need to reflect upon, in the setting of critical illness with everything we're doing and how sick that individual may be becoming, can we actually achieve that goal and can we honor that goal for that individual? So in doing so, we need to understand the cancer diagnosis, what the prognosis is, what's the likelihood that they'll achieve survival and that quality of life without the critical illness, what treatments are needed to get there and have they received those treatments yet? Then we need to take into consideration that individual's baseline functional status. And as many of you know, function is critical with regard to candidacy for chemotherapy. And it's also critical for us to understand because function coming into the ICU will impact function leaving the ICU. Your cognitive status, age, and other diagnoses also are important. And then obviously the critical illness cause, the severity of illness, the number of organ support that that individual may require, and what survival would look like. So all of these factors are needed to inform whether we can achieve that type of survival for that individual. And in creating a niche in the area of critical care oncology, we feel that it's critical that in order to answer these questions to the best of our ability, we need more data on the different types of scenarios that can happen across different types of cancers, different types of functional status coming in the ICU, and different causes of critical illness. And we need that data so we can inform our patients and our families of the likelihood of achieving the goal that they want to achieve. So when we go back to think about ICU outcomes in the non-hematologic malignancy population, we know that the majority of patients with sepsis, so 60 to 80% of patients with sepsis will survive ICU. The majority of patients with the severe respiratory failure, so acute respiratory distress syndrome, 60 to 70% of those patients will survive ICU. But what about patients with blood cancers? So many, many years ago in the 80s and 90s, the Society of Critical Care Medicine, which is an American critical care organization, created a task force and a document to try to define appropriate guidelines for ICU admission, discharge, and triage. And they had a section on cancer, and they had a section specifically on patients with hematologic malignancies when they are sick with critical illness to the point where they require mechanical ventilation. And the data, although it was limited, but the data in the 80s and 90s demonstrated that about 90% to 100% of those individuals would not survive ICU. So at that time, the recommendation was that we shouldn't be admitting these individuals to the ICU because what we can do in the ICU probably can't reverse their critical illness. However, let's now fast forward about 20 years, and there's been major advancements. There's been major advancements in cancer care. There's been major advancements in infectious disease and infection control practices. We can now better diagnose infections. We have better targeted treatments for infections. And there's been major advancements in critical care management. And that's driven the death rates or mortality rates in critical care oncology from close to 80 to 100% back in the 90s down to almost numbers across certain cancers that mirrors the general ICU population. However, these critical care mortality or survival rates are very variable based upon many factors. They're variable based upon the cancer subtype, they're variable based upon age, they're variable based upon the type of critical illness, the number of organs failed, how severe the critical illness is. It could be variable based upon functional status. But the bottom line is that critical care mortality has gone down significantly for patients with hematologic malignancies, leukemias, and stem cell transplants. And so now that our short-term outcomes have improved over time, what do we know about longer-term outcomes? What happens after ICU? And very importantly, how does critical illness impact your care for your cancer after the ICU? And unfortunately, for this population, there was minimal to no data out there and definitely no contemporary Canadian data telling us about long-term outcomes of critical illness across patients with cancer, and then specifically leukemia and stem cell transplant. Fortunately, at the University of Toronto, one of our colleagues, Dr. Margaret Herridge, is the international leader in long-term outcomes of critical care, and specifically respiratory failure. So this is a study she conducted almost 20 years ago across the general ICU population. And she conducted the study because patients who developed the severe acute respiratory distress syndrome, their ICU outcomes, their ICU survival was improving. And so what she wanted to look at is, well, what happens after people leave the ICU? Because we really had no insight on what happens after. And so she conducted this multi-center Canadian study and included our site as well. And she evaluated approximately 100 adult survivors of moderate to severe respiratory failure. Of the patients that survived the ICU, about 90% were alive at 1 year. Very interestingly, the major abnormalities that we're seeing were not so much in the lungs, but they were related to muscle weakness and fatigue. What she noticed is that about 18% of patients experienced body weight loss by the time that they were discharged from the ICU, which was an average of about 21 days in the ICU and 25 days in hospital. And the significant muscle loss was really related to the fact that critical illness essentially causes what we call a catabolic state. When your body is critically ill, it almost goes into overdrive because it's almost like you're on a treadmill the whole time the body is stressed and are under critical illness. And this led to significant muscle weakness and fatigue, which explained the significant functional limitations that a lot of the survivors of critical illness, and specifically this very severe form of respiratory failure, experienced. And persistent functional disability was seen at 1 year following ICU discharge. Dr. Herridge's team then continued to follow these patients up to 5 years. And while at 5 years, elderly patients had less functional recovery than younger patients, neither returned to normal predicted levels of physical function. And in addition to that, they noticed that there was a significant amount of psychological problems that were also present, such as depression, anxiety, and in some post-traumatic stress disorder that was seen. And this is consistently described in the ICU literature across different ICU and critical care conditions. In addition to this, most recently, Dr. Herridge's group also looked at the 1 year outcomes of caregivers of critically ill patients in the ICU. And what she did in this study is she included any patients who received more than 7 days of mechanical ventilation and consented the caregivers to be involved in the study. 70% were women and 61% were caring for a spouse. About 70% of caregivers initially upon leaving the ICU and 43% at 1 year reported high levels of depressive symptoms. And while these depressive symptoms improved over time, and about 15% of patients had persistent symptoms of depression. Now, what about hematologic oncology patients? So myself and Dr. Mehta, who's one of my senior colleagues at Mount Sinai, thought that it was time, given that hematologic oncology critical care outcomes are improving in the ICU, that we actually follow our patient population and actually evaluate what happens at 6 months and 12 months with regard to functional status, cognitive status, and psychiatric status as well, following an ICU admission, given the data we have in the general ICU population. And the reason why we propose this study is because of the paucity of data in adults surrounding long-term survival and long-term functional and quality of life evaluation after ICU. We were very fortunate to get funding from the Leukemia and Lymphoma Society of Canada to conduct this study. And the major objectives were to evaluate contemporary Canadian data of ICU outcomes, 6-month outcomes, 1-year survival, and quantifying the physical disability that could be present following ICU. The study is currently still in progress. I do have some preliminary data which I will present, and the long-term outcomes data is still being collected, but I can show you some of the 6-month data that we've collected today. So our goal was to collect data on 400 adult patients with hematologic malignancies who developed critical illness, and these 400 patients were recruited from 8 ICUs across Canada. The average age of the patients that were admitted was 59. 63% of our patients are male, and 75% were Caucasian. About 80% had greater than 2 or 2 other medical conditions. And prior to ICU admission, we asked the patient and the family to characterize their frailty and functional status based upon a scale that we have, the clinical frailty scale. And in the 7 days prior to ICU admission, the average best frailty status was graded as 4, which falls into the category of vulnerable. Similarly, we used another functional status assessment, which is called the Karnofsky score, which is found to be 60, and that correlates with someone requiring occasional assistance. Now, it's important to highlight that the majority of patients that were developing critical illness and coming to the ICU were not coming straight from the emergency room. Most of these patients are patients that are admitted to the ward who are undergoing treatment, and during treatment develop critical illness and likely accumulate this frailty and functional weakness while they're undergoing treatment. And most patients are coming to the ICU about 5 to 10 days after initiation or after admission to the hospital ward. In our cohort, 37% of our patients had acute leukemia. 42% of our patients had a hematopoietic stem cell transplant, 70% of which were allogeneic, and the majority had graft versus host disease at some point in the year prior to admission. We have more granular data that we haven't yet summarized on the grade of graft versus host disease and the activity of graft versus host disease in treatment at the time of ICU admission. Most patients were undergoing chemotherapy, and 63% were receiving first-line chemotherapy, 37% a line of chemotherapy greater than first line, and 5% were enrolled in a clinical trial. In terms of ICU supportive care, of the preliminary patients for which we have data on, so a little less than 400, we have 400 enrolled, but we have the complete data on about 375. So of that cohort, 46%, so approximately half, required invasive mechanical ventilation within the first 3 days of ICU admission. 41% required vasopressors, so cardiac support and support for their blood pressure within the first 24 hours of ICU admission, and likely a higher percent required it later during the ICU stay. And 6% had severe kidney failure requiring emergent dialysis in the ICU in the first 24 hours of admission. In terms of ICU outcomes, 53% of our cohort survived the ICU. Now, this 53%, one can argue, is much better than the 10 to 20% that survived ICU from historic data. But the other perspective here is that this is lower than the general ICU population for conditions like sepsis and acute respiratory failure. And I'll show us a little bit more data surrounding that. I then just wanted to take a quick snapshot of the historically deemed higher risk populations within hematologic malignancy, which include hematopoietic stem cell transplant, allogeneic stem cell transplant, and acute myeloid leukemia. And as you can see here, their survival rates are not very different than the survival rate of the general hematologic malignancy population. I also then looked at those with a higher risk clinical frailty scale, so a CFS greater than 3. Not surprisingly, their ICU survival rate was slightly lower. And then we also looked at a threshold of an age cutoff of greater than 70, and the survival rate surprisingly was actually similar to the overall cohort. We then focused on those individuals that came to the ICU with critical illness, but didn't require any sort of ventilatory support, so no ventilation. And so these are patients that may be coming to the ICU with sepsis requiring vasopressors, but not breathing failure, patients that may require emergent dialysis that requires the more gentle dialysis, or severe tumor lysis, or patients that are critically ill and we anticipate could become worse and need to come for monitoring. And 72% of those individuals survived ICU. And once again, when we looked at the higher risk cohorts of stem cell transplant, allogeneic stem cell transplant, leukemia, the survival rates were also similar. However, when we turn our attention to those who actually require invasive mechanical ventilation within the first 72 hours of ICU admission, the survival rate was lower. It was 32% of those individuals survive ICU, with similar rates across the other subtypes of hematologic or higher risk hematologic malignancy. And once again, this is lower than the general ICU population who develop respiratory failure, such as acute respiratory distress syndrome, that require ventilation. So why is mortality much higher? Why is survival much lower in the setting of respiratory failure requiring a ventilator? So when breathing failure in the setting of critical illness is involved, the whole condition of critical illness is likely more severe. And while mechanical ventilation may be needed to support the breathing failure, mechanical ventilation is exactly what it's called. It's mechanical. It's a form of artificial ventilation. So in the setting of a very inflamed lung, the mechanical ventilator can induce stress or strain or injury to the lung. And this has been known in the critical care literature for many years. And therefore, a lot of what we do in the ICU is try to minimize the stress and the strain and the injury to the lung as we mechanically ventilate the patients. It's called lung protective ventilation. And we wonder in the setting of patients with blood cancers, whether they could be more susceptible to some of this injury that we see in the setting of mechanical ventilation. Another reason is that, as mentioned at the beginning, there are some unusual conditions that cause respiratory failure for which we may not have targeted treatments such as antibiotics or antifungals or anti-inflammatories. Occasionally, it's very difficult to identify the cause of respiratory failure in patients with hematologic malignancy because their immune system is suppressed. And sometimes the organisms that cause pneumonia, while we may be able to identify them, they may be more difficult to treat. They may be more difficult to eradicate. The treatments that are required may be associated with a unique set of toxicities, such as certain antifungal medications for fungal infections. Or because individuals might have been appropriately exposed to antimicrobials at an earlier time in their treatment, they could be susceptible to developing drug-resistant organisms, which are more difficult to treat and clear. So what about the next 6 months across those who leave hospital? And once again, this is just a preliminary look at the data as the data is still coming in on 6-month outcomes. So of the patients that survived ICU and survived hospital, 70% were able to survive to 6 months that we were able to evaluate. The majority of those had a clinical frailty scale, which put them in the category of returning to almost their baseline level of function. And then the last thing that we looked at, in addition to the more in-depth functional assessments and cognitive assessments, which I don't have the data for here, is we looked at return to treatment. And 57% of the patients who we evaluated at 6 months either had completed their treatment or they're continuing on with their planned treatment regimen, which is reassuring. However, 32% of those individuals were no longer a candidate for treatment or needed to undergo a dose reduction or undergo a modified treatment regimen after critical illness. So in looking preliminarily at the data that we have to date for COHO study, approximately half of the patients admitted to the ICU required ventilation. ICU admissions across individuals without ventilation had survival outcomes that are almost comparable to our general ICU population. So that's certainly something that it was good to quantify and characterize. ICU admission across patients who require ventilation had worse survival outcomes compared to the general ICU population. And across those who survived to 6 months, most of them have a good functional outcome, but about a third do not return to their original treatment plan. Now, the caveat to some of this data is that the 2 centers that have recruited the largest number of patients tend to have higher risk hematologic malignancy admissions. So higher risk patients with more complicated acute leukemias or higher risk individuals undergoing allogeneic stem cell transplant. So as mentioned, this is just preliminary data. More details surrounding functional outcomes, cognition, 12-month outcomes are pending, and we're looking forward to having all that data finalized by early 2021 and potentially presenting it again in this form, and definitely publishing the data and also reaching out to our colleagues who are in this space to ensure that everyone's aware of this data so we can bring this to the bedside and inform the individuals that we're taking care of. And this data is really needed to inform advanced care planning and decision-making surrounding critical illness and ICU escalation. So what about the future in terms of hematologic malignancies and critical care? As many of you are probably very aware, there is a major exciting revolution in cancer therapeutics that's currently underway under the category or umbrella called precision medicine. And essentially what precision medicine is allowing us to do is, with more finesse and more detail, to characterize the cancer and then to introduce medications that could target the cancer with a little bit more granularity. And one mechanism is through reprogramming the immune system to recognize the cancer cell and attack the cancer cell. And preliminary experience with these medications across all of the different subtypes of cancers where they're being evaluated has shown some very promising results. However, what we're also learning is that there's some complex toxicities that are associated with these medications that may require critical care support. And one category of these medications are immune effector cell therapy, and I'm sure my colleagues over the next couple of days will be able to elaborate on these therapies in a lot more detail. Now, this was made possible because in the early 2000s, there was an effort to map out the genomic landscape of cancer, so really characterize cancers at the genomic level. And this really laid the foundation for precision medicine with some very promising results across certain subtypes of cancers. So to maybe just step back and reflect upon what's actually happening. So as you know, cancer cells should be recognized by the body as non-self and attacked and cleared out of the immune system. And a synchronized attack against this tumor or this cancer or this blood cancer requires this complex and rapidly evolving interaction between various types of immune cells, including the T cell. But what happens in the setting of cancer is sometimes that T cell is able to hide from the immune system or turn off the thing that recognizes it as something that is foreign. And that's how cancer sometimes can get away and continue to spread. And one such therapy that tries to reactivate and reinitiate and reinvigorate almost that T cell to recognize the cancer and eradicate it is called CAR T therapy. Now, CAR T therapy is specifically evaluated across patients with hematologic malignancy and B-cell cancers. And the preliminary data has shown that across individuals who have these B-cell malignancies, who are failing the standard types of chemotherapy, they may have a good response rate after CAR T therapy. So this is something that's very exciting as an eventual treatment option for patients with B-cell malignancies. However, there are some critical care complications that can arise with CAR T therapy. So as the program was started at Princess Margaret, for example, it was something that was started in combination with the critical care team being aware of the potential toxicities that could arise, which would warrant an admission to the intensive care unit. So this is just a list of some of the complications. I won't go through them in detail, with the exception of one that's called cytokine release syndrome. And cytokine release syndrome is almost like a mimicker of sepsis. It looks like sepsis. It causes this inflamed and over-exaggerated immune response. So while this immune response is appropriately attacking the cancer, sometimes the immune response may be very exaggerated, that it causes inflammation to the entire body and can affect other organs, which is where the ICU team can come and play a supportive role. This can trigger a systemic inflammatory response, shock to the body, organ failure, and breathing failure. And there's different grades and severities of cytokine release syndrome. A large proportion of patients will develop some degree of cytokine release syndrome, but in 10 to 30% across the reports around the world, it could be severe enough that warrants an ICU admission for us to provide supportive care and administer any medications to try to reverse it. So I'm not going to go through this very colorful graph in detail, but it gives a snapshot of when the CAR T cells are infused, and then the red, green, and blue represent the different complications that can arise, and in a subset of patients, ICU support may be needed. And as we learn more about the different types of CAR T therapy, immune effector cell therapy, and more about precision medicine, we're going to see an increasing number of cases requiring critical care admission. So it's absolutely essential that we have increased collaboration, not just between critical care doctors and oncologists and hematologic malignancy specialists, but also more engagement of patients and family members and caregivers, so we can understand the implications of these toxicities on your health and what happens after ICU. And we definitely need more data, particularly in this space, so we can then understand what happens after people leave the critical care unit. How does that impact what happens to your treatment and what happens to your cancer? And what myself and Dr. Mehta eventually would like to propose is us having a national registry where we can have this data available at all times, and then we can take the data, analyze it, and then present it to anyone who's making decisions about coming to the ICU. So given this increased need for collaboration, myself and my colleague Michael Detsky created something called the COIN Network, the Critical Care Oncologic Investigative Network, where we're trying to essentially develop optimal knowledge surrounding critical illness in oncology patients. We want to enhance communication with key stakeholders, conduct research dedicated to improving care, and ensure that our processes of care and how we manage critically ill patients with cancer is always driven by the best evidence available in the world. And where the evidence doesn't exist, be at the forefront of developing the evidence. Through COIN, we have education initiatives. We've created a fellowship, so training for trainees that are interested in this area. We have a series of research initiatives and quality improvement initiatives to try to enhance the care that we're delivering at the bedside. So in terms of the new therapies, they've led to sustained cancer control across a subset of different cancers. It's leading to an increased prevalence of patients presenting with critical care complications for which the ICU will need to get involved. And we need, as a critical care community, to become more familiar and be prepared to how to deal with the volume of patients that could be coming in the future, given the changing landscape of treatments. So in summary, through the COHO initiative, we're going to complete the characterization of contemporary Canadian data of critical illness across individuals with hematologic malignancy and define their short-term Canadian and their long-term outcomes. We want to then reflect upon high-risk cohorts, so individuals whose survival rates may be low, and evaluate, well, what can be done differently with that patient population? Do we need more targeted antimicrobial therapy, more intensive ICU rehabilitation? And then we need to, with this data, build programs to try to improve outcomes. Across those who have poor ICU survival rates and non-modifiable factors, then we need to increase education surrounding advanced care planning to ensure that we're not delivering overly invasive or painful or overly aggressive care in the intensive care unit. We need to better define CAR T therapy short-term and long-term critical care outcomes, and there's some preliminary data for a study that we contributed to that should be coming out soon. We also feel that it's important for us to develop a critical care oncology registry, so we have continuous data of patients who develop critical illness and a continuous definition or summary of the outcomes. And we feel that this data is necessary to bring to the bedside to help define what we can and cannot do in the ICU and the implications for cancer care in the future. So I hope in these last 40 minutes, I provided an overview of what we can do in adult critical care medicine, some of the unique features about critical illness across patients with leukemia and stem cell transplant, the frequency of critical illness. I'm really excited about us completing our COHO study and having accurate data surrounding our critical care outcomes across this population. And I also look forward to a lot of collaboration with our oncology colleagues and the Leukemia and Lymphoma Society of Canada about critical care in the future. And as I mentioned at the beginning, patient and caregiver engagement is really the future, not just of critical care, but I think of medicine. So please jot down my email address. I'd love to hear from you if you have any ideas, things that you think that we should be focusing on as a discipline. We'd love your insight. So thank you so much.
Thank you, Dr. Munshi. Thank you so much for your time, for your expertise. At one point, I forgot I was the moderator because I was so enthralled in what you were sharing. So thank you for that. It's now time for our questions and answer period. As I mentioned at the start of the presentation, I invite you to continue asking questions through the question box in your GoToWebinar panel. I'm going to combine two questions. I'm hoping they're related and you might see some commonality between them. So, you know, as you can imagine, it's on top of mind for a lot of people who've had cancer treatment around the risks associated with COVID-19. And so one of the questions is, you know, I had a SCT 3 years ago for acute leukemia. Am I at risk for severe outcomes if I get COVID? And maybe the second part to that is, are there any steps I can take to reduce my chances of encountering critical illness before and during my treatment?
So regarding the first question about an individual who is 3 years post stem cell transplant for acute leukemia, so congratulations. We never see patients when they leave the ICU, so it's amazing to hear from everyone and to hear from patients. Not to say that you were in the ICU, but we never see what happens after people leave hospital, which I know my hematologic malignancy colleagues see all the time. But it's just a nice it's nice to hear from individuals once they're through with their treatment. In terms of risk of COVID, so it really depends upon I guess what's going on with regard to your stem cell transplant care currently. So if you're an individual who's in a state whose leukemia is controlled, you're essentially curative from a stem cell transplant standpoint, and do not have any risk factors that puts you immunocompromised. So you're not requiring steroids for graft versus host disease. You don't have graft versus host disease of your lungs. Those are what I would probably consider risk factors for developing more severe illness in the setting of COVID-19. So if you're essentially cured, no longer have any other what we call comorbid conditions, I would say your risk of acquiring COVID-19 would probably be similar to the general population, but the risk of acquiring COVID-19 is very high across the general population. So it's, I think, absolutely imperative that everyone stays extremely vigilant to try to stay clear of COVID. However, as you add in risks that suppress your immune system, so steroids or any sort of immunomodulators like cyclosporin, tacrolimus, what have you, for graft versus host disease, any lung involvement for graft versus host disease, I think the risk of acquiring may be higher because your immune system is suppressed in that setting. And then what we do know from the limited data we have so far of COVID-19 across patients with hematologic malignancies, the severity of critical illness could be higher. We only have very preliminary data across the world on this. And the likelihood of surviving is a little bit lower than the general population, which reflects kind of the data across all hemolignancy with respiratory failure compared to non-hemolignancy with respiratory failure. So the risk is very much individualized, but I think the take-home point should be, irrespective of your risk, irrespective of your immunocompromised status, the risk of acquiring COVID because of the transmission is so high that the best thing to do is comply with local measures surrounding specific restrictions. And I guess in this case, being particularly vigilant about infection control practices such as minimizing your time exposed to other people, masking, hand hygiene, etc. The second question, if you could maybe read it again, was it about what puts people at risk of higher severity of illness?
Yeah, no, sorry, let me read it again. The question was, are there any steps I can take to reduce my chances of encountering a critical illness before and during my treatment?
So that's an excellent question. And I wish I had an easy answer for you. Unfortunately, a lot of the critical illness that we see in this population is at the height of immunosuppression. So the nadir of the white count, and a lot of the causes of sepsis and respiratory failure are things that are not really preventable. So they tend to either be what you guys may be familiar with, opportunistic infections, so just normal organisms in our body that really only cause infection in the setting of being immunocompromised, but the state of becoming immunocompromised, unfortunately, is part of the treatment. Central line-associated infections, pneumonias, or gut organisms that then what we call translocate, so they're on the inside of your gut and then they kind of go into the bloodstream. Those tend to be the most common causes of severe critical illness that develop across patients with heme malignancy that come to the ICU. And for the most part, those are not infections that we can really prevent against, because it's basically your immune system barriers that are being impaired in the setting of treatment and in the setting of devices that are required for your treatment. What probably the best defense that any individual can have is their functional status, their nutritional status prior to developing critical illness. So more and more we've realized the importance from Dr. Heritage's work of coming in good function, and the stronger you are coming in, the stronger your body will be to withstand the critical illness. A lot of what we do in the ICU includes early rehabilitation. You'll see patients on ventilators that are awake that will get up and will walk around the ICU because the body just really starts to develop that catabolic state. So the stronger you are coming in, the more likely you are to withstand the critical illness, the less functional decline that you'll have, and the quicker you'll then be able to get out of the ICU, get out of hospital, and be on your way to rehabilitation.
Fantastic, great. There's a question here, and I'm not sure if it's appropriate to answer here or in one of the leukemia sessions later this week. How often do people with leukemia develop other cancers and/or serious conditions?
That's an excellent question. I don't know the answer to that. So that would probably be better, or probably someone like Dr. Murphy or Dr. Chan, who's speaking in some of the subsequent talks over the course of the week, would probably have a better idea of that. What we are interested in looking at related to leukemia and critical illness is, as we try to quantify what the 6-month outcomes is, what happens to your cancer care after you leave ICU. One thing that myself and Dr. Murphy, who you'll hear from over the next couple of days, are going to be looking at are patients who come to the ICU with leukostasis in the setting of leukemia and get chemotherapy in an ICU setting. Is the likelihood of responding to the chemo, is that different in patients who have chemotherapy administered when they're critically ill compared to those who are administered when they're not critically ill? And hopefully through that study, we'll be able to follow patients long enough to also see, as you've highlighted, other I guess, serious illnesses that could potentially arise across this population when we follow them.
Perfect, thank you. You spoke earlier about precision therapies, and you touched on CAR T-cell therapy, which, you know, there's a lot of buzz and excitement around. We have a participant who's asking, how does one get evaluated for consideration for CAR T? And I don't know if you have any insights on, you know, how it might differ from diagnosis to diagnosis too.
So once again, this is probably one that could be better addressed by my hematologic malignancy colleagues, but it's my understanding in Canada, CAR T-cell therapy in the adult population has been approved for certain B-cell malignancies, so B-cell lymphomas, certain follicular lymphomas, and in young adults with B-cell ALL. Most patients that are candidates for CAR T therapy become candidates after failing multiple lines of standard chemotherapy, which are currently the standard of care. And I know there's some experimental trials going on looking at CAR T therapy across multiple myeloma. So the best way to know is really to speak to your oncologist about that, because they would have the criteria, they would have the number of lines of chemotherapy that someone would have to not respond to in order to be eligible. And I think outside of having non-responsive disease, there may be certain functional outcomes and functional status that's also necessary before you receive this type of treatment, because in the patients that we've seen come to the ICU with severe either cytokine release syndrome or neurotoxicity, those individuals can become quite critically ill. So I think the oncologists really want to make sure that anyone that they're providing this medication to are in the best functional status possible to be able to withstand the potential critical illness or adverse events that could arise as someone's going through the treatment.
Fantastic. You spoke, quite a bit in detail about issues around fatigue and offset muscle weakness post-ICU. And it sounds like it's something that, though it does improve for many patients, it's a lasting impact from their treatment. Can you talk a little bit about what should a patient do at home to help offset muscle weakness and fatigue, and perhaps how caregivers might think about their role in that?
Absolutely, that's an excellent question. So pre anyone developing critical illness, it once again really comes down to enhancing nutrition and function, so physical activity. So the more you work a muscle, the more it's going to stay in shape, quote unquote. So pre-ICU, those are probably the two biggest factors. Nutritional status, functional status, getting adequate sleep and adequate rest so you don't overwork your body. After ICU, particularly during recovery, so leaving the ICU or even not in the setting of ICU, leaving hospital, it still comes down to those two factors. And if people want to inquire about the type of physical therapy that someone should be doing, oftentimes many programs and many hospitals have physiotherapists that can provide insight on the type of activity, whether it's walking, whether there's muscle strengthening activities. But those would probably be the best individuals to evaluate an individual, evaluate what muscle groups may be weak, and they could give you insight on where to focus your rehabilitation on.
Fantastic. Thank you so much. I think we will do one more question. There's quite a bit. I just want to send a reminder to everybody too, before we ask the final question, that there are 4 other sessions focused specifically on ALL and AML that take place tomorrow at 1 and 3:30. And on Wednesday, CML will be held at 1 o'clock and CLL at 3 p.m. So I'm noticing some very specific questions, and they're fantastic questions. We really encourage you to come out tomorrow and Wednesday as well. The last question I'll ask is, we hear about a new normal after treatment. Any tips to help with moving back to a new normal after critical illness?
So excellent question. And once again, so what I hope that we will have, so right now the long-term outcome data that I presented specifically is related to moderate to severe acute respiratory distress syndrome across the general population. So what we're doing with COHO is, we're looking at not just respiratory failure, we're looking at all types of critical illness. So sepsis, treatment-associated toxicities, or respiratory failure. So we hope with the data, we could actually better define the spectrum of conditions or states that people may be in after treatment. So functional impairment will be one that we look at. But we're also going to be looking at whether there's cognitive or thinking issues, any anxiety that people feel. So I think based upon what we see happening and the prevalence of that could help us target what type of follow-ups that people need. So once again, it comes down to rehabilitation and enhancing function. Tied in with that is obviously nutritional status. Tied in with that is there's a subset of individuals who get followed in post-ICU clinics that are now set up in a lot of centers in the States, and something that we've been talking about doing here in Canada, where they actually require some psychology or psychiatric assessments or ways to kind of help with their cognition and thinking. So I think right now we extrapolate the ARDS literature to all ICU patients, but we hope that when we have the cohort data defined, we can see specifically what's unique about hematologic malignancy. Are there any things that are different than the general ICU population, and then try to target what we do in terms of recovery based upon that data.
Great. Thank you so much again, Dr. Munshi. And for all those who participated in the webcast today, again, if we didn't get around to answering your questions, we really do encourage you to participate in the other 4 sessions that will be a bit of a deeper dive into specific types of leukemia. So again, thank you so much, Dr. Munshi. I'd also like to thank our marquee sponsor, Astellas, and a big thank you to AbbVie, AstraZeneca, Bristol Myers Squibb, Celgene, Janssen, Jazz Pharmaceutical, Novartis, Paladin, and Pfizer for making it possible for us to host our National Leukemia Conference this year. Before signing off, I'd also like to, again, just remind you that we're here for you. We hope that today was informative and that you learned some new content to hopefully support your cancer journey. If you're looking for more specific resources and support, please contact us by dialing 1-833-222-4884 or email us at canadainfo@lls.org. We will be circulating a short survey to our participants after this webcast. Please give us feedback. We are always growing and learning how to better serve and support you. So take the time to give us that feedback. Thank you for joining us for our first LLSC 2020 Leukemia Conference session, and I hope you all have a wonderful day. Bye.
Thanks for having me. Bye.
Of course. Thank you. Take care. Bye-bye.